I'm delighted to welcome our next panelists here. They are going to be talking about how emerging technologies like cognitive AI, blockchain, edge are actually transforming the healthcare system. Today's session will be moderated by the very talented Dr. Brigitte Piniewski. She is an author. She is an angel investor. She is a physician. She is an executive. She is the author of the book Wealth Care. Nobody better to actually lead our next session. So without much ado, I'm going to hand it over to you guys.
Well, thank you all for being here, and thank you TiEcon for inviting us to this important panel. I want to assure all of you, you are in the right room. This is definitely the place that you want to be. We have an amazing panelist here to speak to us about the future of patient-centered care. Patient-centered care has been an acronym and a discussion for a number of years, decades even, but now we have the technology to underpin a very new approach. So here with me today, this is the physician panel, so Dr. Reena Bhargava. She is the Senior Medical Partner of Digital Health, Telehealth, Virtual Health at Kaiser, Internal Medicine Specialist, as well as we also have Dr. Zachary, Senior Vice President of Global Health Business Development at Babylon Health, also an internist and hospitalist by trade. Let's begin by a short introduction from each of you. Reena, do you want to get started?
Certainly. Hello, everybody. Thanks for making time this afternoon. We had a really exciting panel ahead of us. Thank you, Brigitte. I'm a practicing internist at Kaiser Permanente. This is very much my area, Santa Clara and so forth. And I've been a medical director at the Appointment and Advice Call Center. So that's our telehealth platform, and been doing that for more than 16 years. We've also been in the digital health platform, doing some innovations there. And frankly, one other thing, this is the usual stomping ground for my husband, who's, computer science, visual search, and augmented reality, and all of that. I used to get the nudges. It's kind of somewhat crazy that we've changed places.
Thank you, Reena. Marcus.
Hey everyone, thanks for coming. So I'm Marcus, I'm a physician. I've been in healthcare for almost 30 years now. Spent 10 years in the Dignity Health system, so hospital side. Did a 2-year detour with that, helping them install Cerner. And then I moved to the provider side, working for one of the large IPAs in the Bay Area, and then took a step into the startup world, working for a company focused on value-based care and population health medicine. And since 2019, I've been working at Babylon Health, which uses AI technology to bring accessible and affordable care to everyone on Earth. Excited for our discussion today.
Great, thank you, Marcus. And let's begin by just sharing with this group one or two of your most exciting data technology projects that you've done at your enterprises that really highlight the ability of the physician to contribute to what works on the ground in healthcare.
Happy to take that. I think one of the innovations that we're really proud of, and I was the physician leader for that, was developing electronic physician visits. And so these are asynchronous visits. We're not talking about virtual health. We've been doing telehealth for more than 15 years. Really robust clinical decision support systems that we've developed for the longest time. And then we'd gotten into video visits more than 8 to 10 years back, so that we were in a really strong position. And by we, I'm talking about Kaiser Permanente, Northern California. We were in a really strong position when we got hit by COVID, and nobody wanted to leave home. And it's interesting that the tiny percentage of patients who were pushed or strongly encouraged to video visits suddenly embraced it completely, so that 40-50% of the care could switch over to that platform. But prior to that, July 2018 or so, we had deployed electronic visits. These are asynchronous. You can get your prescription within a couple hours of submitting that for treating what might be sinusitis or UTI or something, some real care. And so when COVID did come along, we could pivot to a whole different system, and it's really kind of omni-channel. Every patient wants to do, every patient out there wants to access healthcare on their own terms. And with these electronic visits, they could do that even on the smartphone. So we built the physician side of things to the point that the response and the whole care could happen within 2 to 3 minutes, because of all the smart sets, the smart phrases, everything else we've built together. And this is something that could be used in remote locations. Could definitely be scaled up for the pandemic, but again, where you do not have care, you may well have a smartphone around. And so that's, I think, one of the exciting pieces.
Well, and what I really heard with that as well, Reena, was this ability of the individual patient to negotiate new technology to participate with healthcare. Up until now, we've left patients on standby, asking them to come in and see us only if they needed some care. But given the technology, patients, communities, and households can behave very different if you provide them with the technology to support them. Marcus, do you have a project that you would like to share with us?
Yeah, so I think back, this was, must have been like 15, 20 years ago. I remember I was reading in The Economist about in fintech how in Africa there was a leapfrog moment in banking. People had been going to like Western unions to deal with their money, and then some bright people realized, geez, everybody's got a mobile device. Why don't we just do banking mobily? And it stuck with me because of the irony. Here I am sitting in the United States, and people in Africa are able to do something much more technologically advanced with their phone than what I can do in the US. So fast forward, I'm working at Babylon, and we had the opportunity to collaborate with the Bill and Melinda Gates Foundation to do something with the national government and the Ministry of Health in Rwanda. Babylon has an AI-enabled virtual digital primary care model and platform, and in this grant, we deployed it across the entire country so that citizens could get virtual primary care on the mobile devices they already had. And it was so successful that the government actually decided to pay for it on a 10-year term, and now 40% of the Rwandans get basically free primary care through our entity in that country, which is Babel. And so I think in the mission of affordable and accessible healthcare, it's an extraordinary accomplishment.
Excellent, thank you. And you remind me of that innovation that I do this frequently. I let my panelists introduce themselves, and I don't introduce myself. So let me get that done quickly as well. With respect to my background, also a physician, spent my first part of my career doing a lot of maternity work, prenatal, delivery, postnatal work, and then moved on into medical administration for one of the largest reference labs in the Pacific Northwest, looking at how we could use technology to ensure that our populations would be healthy throughout the decades of their lives. And then subsequent to that work, I began advising with investors, TiE, Oregon, and other Oregon Venture Fund, et cetera, around health technology. And what was clear is more and more solutions, more and more startup teams were providing blockchain-based solutions for which none of the investors in the room had any background. And we had not trained in blockchain, we had not worked in blockchain. So I set up investor education programs because who wants to sit by themselves and learn these things on the internet? With an investor group, we could have 3 hours of online education followed by 3 hours of in-person instruction and get to the space over a couple of weeks with 30 of your best colleagues to a place where all of us had at least a working understanding of the benefits of blockchain, crypto, tokenization, and this future of a Web3 model. One of the things that the previous panels have not talked about yet is the engagement of the individual as a key participant in the co-creation of health intelligence, the health intelligence that we need to build new wealth into the system. So we hope to talk a bit more about that. But before we get there, let's go back to our panelists and just touch on some of perhaps the darker sides or the shadier sides of getting into a technology future. Have you hit some rough patches that taught you to be more cautious moving forward?
Not necessarily something that happened in my company, but it's something I read about in the New York Times, which I thought was poignant to the subject today. So it describes an individual in the Bay Area who was using virtual digital health for something that was affecting their child, and they took a photo, sent it to their doctor, and their doctor gave them a treatment plan. But then shortly thereafter, they were shut out from everything that was, I think it was Google. They had everything on there, their banking, their passwords, their email, everything. And ultimately what the root cause was the image was loaded up to the cloud. It was monitored by AI. And they were flagged as potentially is this someone who's a child molester who's taken a picture of a child in a sensitive area. And so anyway, the article goes in to a number of different areas related to this topic, but for me, I think it was just a striking example of number one, for myself, I better not put everything in one cloud base, but also coming into the work that I do every day as now the Chief Clinical Officer and a member of the senior leadership team, there's going to be unintended consequences from this technology that we built. And so we have to create governance, we have to create safety, and we have to create a continuous communication plan to understand when something is going unintended, that we get on it right away.
And we discussed this earlier, and I was sharing. We've developed clinical decision support tools, and that's exactly what we need with the telehealth platform, so that when one of our 4.5 million patients in Northern California call the doctor's office, the phone rings, the person who's picking up the phone, one of the 1,000 maybe clerical frontline folks, has a clinical decision support tool to tell them what to do, follow the directions, and so forth. Backed up, of course, by the nurses. We've got a similar number of nurses, each one of them, again, highly trained and following these protocols that we've built, together with the chiefs of, say, ophthalmology or chiefs of ID, infectious disease, and so forth, using guidance. But at the end of the day, it is the practicing physician who takes care of the patients and he's seeing the whole perspective, who's building these tools. And so as far as, these concerns, which may be sensitive, we'd reviewed it, and maybe about 6 or 7 years back, as we opened up video visits for our Northern California Kaiser patients, we absolutely offloaded sensitive issues like sexually transmitted infections, anal problems, rectal problems, things in the groin, those kinds of sensitive spaces. And I think, again, it is because the patients at the center of our thought process as we're building this, what works for them, what are their needs, what are their wants, and what are the limitations for practicing physicians. So interestingly, those particular symptoms and reasons were not made available for video visits. Most everything else was. So it's, as Marcus shared about this incident, I'm like, okay, these were the safeguards. And so at the end of the day, we have to have safeguards. Whether it is to keep our patients safe or keep ourselves legally safe and so forth. And especially with generative AI, more so, I think most people in this room have heard enough out there. An amazing, amazing tool, but yes, there will be fallacies, there will be hallucination, and we do need the subject matter experts and practicing physicians and so forth to be at the center of building this as well.
Yes, and in that vein of generative AI and AI, I think what we're hearing is that the AI itself is only as powerful as the raw material that it has access to. And today in healthcare, we are stuck with just clinic visits, hospital visits, which make up such a tiny fragment of our lives as individuals. And it informs care pathways, yes, but it doesn't inform life pathways as well. And our previous panel talked about us as individuals managing our own health data. That would put us in a position that we could, in fact, start to really understand the non-medical therapies that work best. Perhaps yoga is more effective for migraines than some medications. Perhaps there are opportunities to learn from each other in ways in which the healthcare system will never be able to understand, because these are not scientific insights that can be gleaned from randomized controlled trials. And so what we're seeing now is a future where our previous panel said, look outside. One of those outside spaces is the cannabis space. Cannabis is, by definition, not allowed inside of traditional healthcare. There's no IP there with a natural product. So cannabis users are trying to figure out how to use medical cannabis in ways that will be effective for their sleep, for their pain, and many other ailments. So what we're seeing is a use of technology, blockchain and Web3, that keeps the individual's identity safe and secure while they document their experience with cannabis therapeutic. And of course, we have very good data around the therapeutic itself, because there are regulations in place regarding seed to sale. So we have the DNA of that plant that was used for this person's sleep disorder. But we rely on that patient, on that individual, to share with us how well and how effective that medication was for them. And so we start to see, outside of medicine, these models where the crowd is collectively creating a data union of sorts that generates not just intelligence for themselves personally, but also for the community at large, so that you have greater and greater intelligence over time. This model, we talk about wealth creation. Well, all new wealth is created from new knowledge. And we are seeing groups and communities collaborating through data and technology to create new scientific insights to drive new products and services. And they're doing that through a Web3 type interface. And just to let you know, I've just launched the Web3 book called Wealth Care, looking at a future where individuals participate not just in curating their own data, but also tokenizing and creating a model by which your personal health data becomes a digital and economic asset that you manage and control. And by becoming an economic asset, you start to create a much stronger value proposition for individuals. We used to say, track your steps because it's good for your health. But that's not a strong enough value proposition for very many people to participate. Now we're looking at a place where we can, in fact, increase the economic benefit of our data if it is associated with the contextual data that allowed us to achieve certain health outcomes in the first place. So for instance, if your laboratory data is worth a certain amount on the open marketplace, your HDL not worth much in isolation, but if you have the step data, the movement data, the nutritional data that backs up your HDL, it suddenly becomes much more valuable. So looking at a future where we as individuals are co-producing the health intelligence that's required for healthcare, not just to do the right job with respect to the right drug for the right person at the right time, but really to build out these progressive AI models that allow us to understand and see around the corner before pathology hits in ways that wasn't available previously. One thing that is quite common in healthcare that perhaps the audience is not that familiar with is that we treat each individual as a population. Do either of you want to clarify what that means with respect to how we're looking at patients?
Well, mostly we are guided by data, by research, to give us a sense of if I put my patient on, say, a statin, a lovastatin, a atorvastatin, everybody's familiar with that, hopefully, those cholesterol-lowering medications, there's an absolute risk reduction maybe of 2% for maybe a 40-year-old male. So all of that is kind of population-driven statistics. But when I bring it down to the personal level, and this is where your personal care physician really matters, and then knowing all about you matters, I do need to factor in a few other things, and that would be if I throw in their family history, I throw in any of the logistics or risk factors that we're thinking about, and then personalize it for them to say where we are. So to me, that maybe you're alluding to something slightly different, but that is beyond, you do take data from the populations, and there are amazing amount of bodies that help us guide that decision making, and then bring it down to the individual to say, where are they, and what can we do to get them to the best level, next level.
Yeah, I think what we're talking about is just within the context of AI, and where you're getting those data sets is that there is inherent bias in those data sets. I think maybe folks don't know, but one of the problems that we have with drug trials that lead to the approval of medications is the majority of those are done with people who are in their 30s to maybe late 50s, and they're mostly white. But once those drugs get approved, we obviously give them to people outside those age ranges and certainly different ethnicities, and they have different responses. And that's what you see clinically, but then this will get magnetized or magnified as you start to apply that within an AI data model. I know within my own company, one of the things that we've been working on is, as we're developing a care plan, we want to understand more on an individual level. It would be great, and we can get into some of like the tension between transparency and privacy when it comes to personalized data, but at least, for instance, we should have some availability to know that, okay, you're telling us about your steps, you're keeping a food journal, and we have your SureScripts, so we know whether you're taking your meds or not. And then based on that, the AI can adjust and make a recommendation that for you, you're doing the exercise, you're eating right, but you haven't been taking your meds. That's what you should really focus on, instead of the usual gestalt that we say, oh, you got to modify your lifestyle and do all these things. And a lot of times that just doesn't work. So doc, give me the one thing that I should really focus on versus maybe another patient like me, and I haven't been exercising, but I have been taking the pills. It's a different set of recommendation. It's a rudimentary start, but that's where we're going when we talk about individualized medicine.
Yeah, and this is where, of course, the individual patient can help out a lot. With population-based studies, the things that drive our care plans, our clinical guidelines, these are offering average. At the end of the day, patients come in to see the physician, but the physician sees the population with some caveats that we just shared. At the end of the day, that means if I'm a diabetic, I'm going to get an average lifespan of a diabetic. And yet we could have all of the diabetics offer us their previous experiences through digitizing their physical health through these new models to allow us to understand what are the co-occurrences for me to actually reach optimal. If Reena diagnoses me with stage 4 breast cancer, I don't want an average outcome. I need an optimal outcome, and that means all of the women previously not letting their experiences go to waste, to evaporate over time, but really to take charge of their physical health expression, digitize it to their greatest degree possible, and make it available to data marketplaces so that people like myself can have access to them over time. Finally, the reason why we call the book Wealth Care is because we expect this to be the next wealth inflection for society. Today, you and I had 2 or 3 transactions. We might have bought some coffee, did something online. But in a future where the individual is amassing a longitudinal health record that is highly verifiable through these new technologies and participating in marketplaces, we would expect that the 3 of us may have had a couple hundred transactions already today happening in the background on our data that we have pre-authorized using the principles of a Web3 ethos. So we're out of time, but I just wanted to give you an opportunity for your last thoughts.
My last thought would be, I think we're at an amazing point, totally catapulting into a different way of taking care of our patients and our health. And generative AI does this. When our patients are choosing to wear Libre and so forth, Dexcom, and sending us immense amounts of data that I, as a practicing physician, do not have the time to sleuth through. But if generative AI with safeguards can help me, crystallize that and then make meaningful recommendations, we're in a whole different place. And I'm really optimistic. I think this is exciting. The discussion next year is going to be very different.
Thank you.
Yeah, I agree. I can see finally work that I was doing when value-based care and the Affordable Care Act passed, that all the pieces are coming together now in a way that we can have individual, real-time healthcare, but there's gonna be some rocky turns along the way, and then I just can't help myself. I've got to just take, I don't know if Peter's still in here, but as far as Amazon goes, they tried to do healthcare, they got out of it, and then they were so desperate, they paid $4 billion for a business that hasn't had a profitable year in almost 15, and no offense to Amir, he's a friend, but drop the mic with that.
And finally, just to let you know, this will be the first formal book signing. If anybody's interested in a copy, well, that will be outside at the end of the healthcare track, and happy to sign it for you. There's a limited number, but please drop by. We'd love to have you read this message. Talk soon. Thank you very much, you guys.